Well, our discussion has been phenomenal as usual. I want to thank you guys for joining us. Perhaps before we close, let's think about the challenges that we face with the treatment of chronic pain, any types of pain, nociceptive, neuropathic. Charles, any final thoughts, any recommendations to our viewers, whether it comes to safety or multimodal analgesia or anything about novel technologies on the horizon?
Don't overstep your bounds. It's okay. And please keep in mind that everyone is different. And so don't have a mindset that everyone's going to respond to the same cocktail, to the same multimodal approach. And this is an area where we are learning a lot, but we have learned how personalized the approach has to be.
That's great. Chris?
Several summary statements I'll make, Jeff. One of them is that the pain number, the pain score, is not a primary outcome marker. It's one of the outcome markers. Really, the core outcome is function. And the other message, as was eloquently stated by all my colleagues, is that pain is multi-mechanistic. So therefore, focus on the anatomy, including the peripheral nervous system, the central nervous system, the ascending pathways and the descending pathways. That doesn't mean that you're going to target all of them, but you need to target the ones that matter through a combination approach that's not too complicated. So what that generally practically means is find one or two medications that are working for your patient through a reasonable titration. Not overmanagement, not rapid conversion, but a reasonable titration that allows the medication to work. So don't overmanage. Give it a 2 to 4 week and then see your patients and then measure those outcomes. That's great, thank you. Vitaly.
Well, being what I think is a comprehensive pain management physician, but also an interventionalist, I want to emphasize the high-touch and low-tech approach. I've seen patients who came to me, and one of the first modalities that was tried was a peripheral lead, spinal cord stimulator, peripheral lead for post-herpetic neuralgia. And a lot of easier, less expensive steps have been overlooked. So Chris mentioned the role of interventional procedures in post-herpetic neuralgia. I think they have a certainly, if not secondary, probably more like a tertiary role in these patients. And really talking to the patient, learning which aspect of their lifestyle is the most affected by this disease is very important. I remember this gentleman who had this, what is called anesthesia dolorosa in V2 distribution, like Chris mentioned prior, that the patient had painful numbness in the face. This gentleman came to me and his complaint was that he could not allow his wife to kiss me, to kiss him. That was just really something that I remembered. That was during my training. I remember this for the rest of my clinical career. So really talking to the patient, learning these, what characterizes the patient's response, how the disease affects the patient is very, very important.
Great. Joe?
Well, first, great comments from all. If I could maybe just add a couple bullet points. Do no harm. I think that's extremely important. These are somewhat fragile patients, as I said. Chronic pain is not monogamous. So keep your hat on, understand you're a specialist. If you're a primary care doing it, just, reach out for help. The second is, when it comes to opioids, I guess, I can paraphrase from Thomas Aquinas. It's not the actual object that is good or bad, but the method of use which may make it so, right? So it's important that we understand that there's the societal element related to opioids. So we need to have in place proper opioid risk management strategies that are comprehensive, that include education, and that set appropriate expectations so that we understand where and what we're trying to get out of our opioids. And they should be driven by functionality and not pain scores. And then finally, I think we have to realize there is no one golden bullet, so we need options, right? I mean, and so the more options we have, the better it is, and we can only hope that not just reformulated, repurposed analgesics, that we start to actually see a new class of drugs, drugs that are topically delivered. Charlie's done a lot of great work with that. Drugs that are focused on musculoskeletal disorders, like what they're doing at NYU, different types of agents, classes of agents. Drugs that also look at the other side of medicine, like addiction, Jeff, things that you're handling every day, and interventional techniques. So it's this myriad that has to continue to grow because we need options.
That's great. On behalf of our panel, we thank you for joining us and hope you found our peer exchange informative. Thank you all.
Thank you.
Thank you.